Dear audience, I welcome you to our another educational session. Today, our topic of discussion is about inherited retinal diseases mimicking as age-related macular degeneration. Age-related macular degeneration can sometimes manifest as different inherited retinal diseases. And it is very important to differentiate them from these diseases because it will ultimately lead to proper diagnosis and management. So, this is something very confusing to our ophthalmologists, colleagues. That's why we have chosen this topic. In order to discuss this topic, we have invited our consultant, our professional colleague, Dr. Lorenzo Bianco. Dr. Lorenzo Bianco is a consultant of inherited retinal diseases and uveitis at San Raffaele Eye Institute, Italy. He has done his fellowship training in Queen's Wings Hospital in Paris on inherited retinal diseases. We are thankful to him that he has accepted our invitation.
Thank you, Dr. Mirza, for the kind invitation, for the opportunity. And of course, I'll try to convince you that inherited retinal diseases actually are quite interesting also for a broader audience. And I will just share my screen in just a second. Should be okay. Okay. Can you see the slides?
Yes, please proceed.
Okay, of course, we know what are inherited retinal diseases. So basically, genetic disorders of the retina, these are rare conditions. But when grouped together, the prevalence is actually not that rare, it's about 1 in 2,000. These are neurodegenerative conditions that affect mainly the outer retina, and some come in syndromic forms. And when we think about inherited retinal diseases, we mainly think about retinitis pigmentosa, of course, with the specular pigment and the autofluorescent ring that is called Robson of the ring, and with the loss of outer retinal bands on OCT. But some inherited retinal diseases actually come in a different flavor. They may mimic age-related macular degeneration and its signs, as of course we all know, the drusen, the geographic atrophy, and also the MNB. And some patients actually present like this, so a huge amount of drusen at the posterior pole that, however, are hyperautofluorescent. This is really strange for AMD. And when we do the OCT, we see a large amount of sub-RP deposits. This is also really strange that come together to form a large plaque at the posterior pole. This is very atypical for AMD. And also because of the age of the patient, we diagnosed her with Doyne's or Leventinese macular dystrophy. But this is just an example to introduce the topic. And I want to at the end of this lesson, I would like to you to be convinced that not every patient that presents in the clinic with drusen, geographic atrophy, or macular neovascularization, or both perhaps, is actually affected by age-related macular degeneration. And I will present some cases. So this is a case-based presentation to convince you. I will start with this other patient, a female one that presents with bilateral geographic atrophy at the posterior pole. I will try to use the pointer. That mainly involves the entire posterior pole in both eyes. We do the autofluorescence, we see again very extensive hyperautofluorescent alterations around the geographic atrophy. We do the OCT. Surprisingly, in one eye, she has foveal sparing. In the other eye, interestingly, she has extensive atrophy of the outer retinal layers and also outer retinal tubulations. This is an interesting sign on OCT. And this patient also had that deafness. She was having troubles with her hearing capacity since a very young age. She also had diabetes mellitus. When we put all these science and findings together, of course, we diagnose her with mitochondrial retinopathy. This is a relatively new addition to our field in the sense that this was firstly described in the more severe syndrome that's called MELAS, and is also has strokes and so on. In some patients, actually, the retinopathy is the main finding, and then they have also diabetes, but the retinopathy can be the principal or the initiator of the diagnostic journey of these patients. And it's important to recognize, since this has a strange inheritance pattern, this is maternal. So it comes from the mother, and the females pass it on to females. It has a variable expressivity and a relatively fast progression. As you can see from those images, another patient progressed a lot over the course of few years with atrophy, actually involving the fovea and progressing also in the rest of the posterior pole. And it has this flake-like lesion that turn around the optic disc. This is very typical also. We have another patient, again a female, 49 years old, comes with a little patch of atrophy in the right eye. Again, speckled hyper and hypo autofluorescent alterations at the posterior pole mainly, with a tiny patch of atrophy in the fellow eye. When we do the OCT, we see complete loss of the RPE in the right eye. Again, foveal sparing and some subtle alterations of the autoretinal bands in the left eye. This patient has central areolar choroidal dystrophy that's caused by PRPH2. It is autosomal dominant in contrast to mitochondrial retinopathies that are maternal. This is dominant, so 50% chance at each child of an affected patient to be affected, also the child. It has a huge variable expressivity, and it's important to note that only some missense variants of PRPH2 cause this particular phenotype, as most of the other variants in PRPH2 cause just mild vitelliform dystrophies or retinitis pigmentosa. This is very specific of these codons mutations. We have to remember that also another gene can cause central areolar choroidal dystrophy, as in this patient. However, CDH1 normally causes very severe conditions, so like retinitis pigmentosa, early onset severe retinal degeneration. When we have this particular variant here, there is a synonymous variant that ultimately causes also some troubles in exon skipping, as described in this pivotal publication. We get this phenotype. It's very mild. We have foveal sparing, and is autosomal recessive. So normally there is no risk for the child of an affected patient. This is very different from PRPH2, where we have a risk. Now we move on to mimickers of patients presenting with MNV. And we have this particular lady, 65 years old, so in the range of age that we would expect for age-related macular degeneration. She has a huge subretinal hemorrhage. She presented in the ER, and we notice in the same eye some stippled alterations in the temporal mid-periphery that's called peau d'orange. And we see, of course, in both eyes, the angioid streaks, so radiating reddish lines radiating from the optic nerve, basically. And the macula looks pretty fine in the left eye. When we do the autofluorescence, we see a pattern dystrophy alterations that radiate again from the optic nerve. That's very suggestive of a particular diagnosis that we will discuss later. We do the OCT, we see a huge macular hemorrhage with most probably a choroidal neovascularization underneath. And when we do the OCT of the left eye, we actually see that there is a small, tiny macular neovascularization that is starting to exudate also in the healthy eye. And when we do the OCTA, we confirm the presence of this membrane and with the flow signal inside it. So it's important to recognize this diagnosis as pseudoxanthoma elasticum, given that it's really keen on developing macular neovascularization. If left untreated, these are really severe ones. It's an autosomal recessive condition that brings with it these typical skin lesions that they have no very much clinical significance, but can help in the diagnosis, especially for the ophthalmologists. These are quite, if you see a young patient with macular neovascularization, if you check the skin creases on the neck, you will recognize this lesion, and this can help in differentiating whether it's just macular neovascularization from AMD or it's something more. And of course, the angiostrix can help. These patients are supposed to be at higher risk of systemic complications, so it's important to diagnose them and to address them to a multidisciplinary team that can take care of them. And it was believed that these patients were only developing type 2 neovascularization. Recently, actually, Maria Vittoria Cicinelli, who is my colleague, discovered that these patients develop huge type 1 nets along the angiostrix, like in this example. And in the late stage of the disease, they get these huge neovascular nets, just, and the entire posterior pole is a macular neovascularization, and then they can perhaps develop a type 2 component with hemorrhage and so on. And it's very important to follow them closely to treat them as soon as possible. We have another patient presented with a subretinal hemorrhage, so probably a type 2 macular neovascularization. The other eye, she has geographic atrophy. She's 61, so again, the age range is more or less AMD. But if we do the OCT, we clearly find a rupture of the Brock's membrane with fluid inside the retina at the fovea. We do the OCTA, we confirm the presence, of course, of macular neovascularization. Surprisingly, this lady had Best disease, which is expected, of course, to develop macular neovascularization, but one can be so surprised that one presents 60 years of age, but it happens with geographic atrophy in one eye and MNV that is exudating in the fellow eye. It is autosomal dominant, so again, there is a risk of recurrence in the child and in the offspring of the patient. And the early stages are relatively, mild as an impact on visual acuity, but MNV is really common in about 50% of eyes it develops, and it's, again, it needs to be treated because otherwise scarring and fibrosis will limit the visual potential of that eye forever. And sometimes it's difficult to determine whether the MNV is actually exudating or it's just a bystander finding, given that Best disease has this subretinal fluid because of the disease itself. So it's sometimes difficult to judge whether it's exudating or not, and the hemorrhage and fundus examination is really key, or fluorescein angiography to check for the leakage. We change gear again. We present some cases that present with both geographic atrophy and MNV. And in this case, we see the right eye as geographic. The right eye is a huge neovascularization with fibrosis. It was left probably untreated for a long time. The left eye has this initial geographic atrophy at the level of the superior temporal arcade. On OCT, we see drusenoid deposits. She's 59. So probably, again, the age range more or less of AMD. But we have some suspects because she has this, the level of the temporal mid-periphery. She has this huge subretinal sub-RPE deposits. So a continuous layer of thick material infiltrating below the retinal pigment epithelium, but also reticular pseudodrusen in another area of the retina. So this association is really strange. We do the ERG, so we measure the function of the retina under electrical and light signals that stimulate the retina, especially under dark adapted conditions. So we measure the function of the rod system, given this is a frequent association between macular dystrophies mimicking AMD and dysfunction of the rod system. And we see actually that there is some attenuation of the rod responses. This is typical for Sorsby macular dystrophy, that is known as the most aggressive, most neovascular inherited macular dystrophy, and usually it presents with macular neovascularization in one eye, and the other eye has this kind of sub-RP deposits and pseudodrusen, as discussed in this wonderful publication. But we need to remember that bilateral geographic atrophy is without any macular neovascularization is possible. So we need to think about Sorsby even if there is no macular neovascularization, so that we can follow our patient and avoid this huge fibrosis that forms at the posterior pole if left untreated. And this one example, there is one particular variant of TIM3 that is the gene that causes Sorsby's, that is associated with this phenotype that looks like central arterial choroidal dystrophy or mitochondrial retinopathies, and they generally do not get macular neovascularization. And in Italy, we almost exclusively see this kind of patients for Sorsby. We don't see the neovascular ones for some reasons that are explained by genetics. But another probably more common case is again a lady that presents with this reticular pattern of flex, a reticular pattern dystrophy in both eyes, and again subretinal hemorrhage that is very, very small, but the patient was complaining of decreased vision in the right eye. When we do OCTA and OCT, of course, we see what looks like a type 2 neovascular membrane, and we do the OCTA, of course, we see this nice network. But why this patient has macular neovascularization? She has a huge amount of flex the posterior pole and also beyond the mid-periphery, and she also had geographic atrophy starting in both eyes. She has Stargardt disease is a late onset form of Stargardt disease that is specifically associated with some hypomorphic variants, so probably variants that are not as pathogenic as the others, and they get the disease only later in life, so at 50, 60 years of age. And this late onset form is associated with foveal sparing. That's good for patients because they don't complain about vision until they are relatively old, but this particular subform tends to develop macular neovascularization more often than the juvenile form. And probably that's because the biology of the disease is more similar to AMD at that point. However, the macular neovascularization is a fairly bad subtype of type 2 membranes with a lot of exudation, hemorrhage, and very difficult to control. However, we also see macular neovascularization in young patients with Stargardt disease with a classic juvenile phenotype, and you see again a huge submacular hemorrhage with nicely delineated macular neovascularization on OCTA. We finished the cases about genetic diseases. I wanted just to point out very briefly another condition that we are seeing currently in Italy. We see a lot of these patients. They present with at a relatively young age, about 55, 60 years of age, with geographic atrophy and this kind of reticular drusenoid deposits all around the mid-periphery and paving stone degeneration. This is called EMAP, extensive macular atrophy with pseudodrusen-like appearance, a very complex name that was adopted in 2009 when the disease was first described. And it is characterized by this invariant association of macular atrophy that is very fast growing, these deposits that are really peculiar, and when you see them at the fundus, it's very clear cut. You see penny stone-like degeneration. The atrophy on fundus autofluorescence has this appearance that is kind of grayish, is different from the AMD one. And you see also this in the retina that is spared from atrophy, you see this separation between the Bruch's membrane and the RPE by some kind of material. And this is not genetic at this point. I mean, we didn't find any possible causative gene. We see these diseases mainly in Italy and France. These are the deposits I was mentioning before. This very all are over the posterior pole. And when the atrophy develops, you get this kind of dust-like material remaining above the Bruch's membrane. You do the OCT on these mid-peripheral deposits, you get probably what's like, again, deposits below the retinal pigment epithelium in a plaque-like or cobblestone pattern. You invariantly have this sparing of the temporal region, the region temporal to the macula. Is evident really from the early phases of the disease, and then it persists even in cases where the atrophy is really huge. We don't know why the atrophy does this kind of turnaround. We will figure it out. And again, if you do the ERG, you find a complete rod dysfunction. The light adapted cone function ERG is relatively normal, but the dark adapted indicates that there is no rod function. Indeed, these patients present because they cannot drive anymore, and but their vitamin A apparently is normal. So I just wanted to point this out, because also this patient, they get MNV and on top of the atrophy, so the risk is quite high. It's 50% at 4 years, and I mean, it's a burden that adds on this very bad diagnosis. And I just wanted to draw attention on EMAP. And I hope I convinced you that not every patient with Drusen GA or MNV has actually AMD. And my message is that you don't need, of course, to do genetic testing on any patient, on every patient you see, but to maintain a high index of suspicion when the patient is relatively young. So before 65 years is the cutoff that I use. When you see these hyper autofluorescent lesions on fundus autofluorescence, if you have it available, it's usually is suspicious. And also fovea sparing. I know that AMD with geographic atrophy can spare the fovea, but when you see a relatively young patient with fovea sparing, usually you are right to think that it's not AMD. And of course, the ERG can help a lot. When you are in doubt and you find rod dysfunction on ERG, this is not normal for AMD. I mean, this is my message. And I want to thank you for the attention and for inviting me, and for the project you are carrying forward on education in ophthalmology.
Well, Dr. Lorenzo, thank you very much. It was very interesting to attend your lecture, and you have very rightly pointed out the important details which are to be kept in mind while managing these diseases. Sometimes the same things overlap and they are mistreated. You're right. A few things I just want to ask. What are the important clinical clues which should raise a suspicion that the apparent case is AMD, not inherited retinal diseases? And secondly, I will just ask what is the morphology of AMD, or the distribution of new vascularization that differ between AMD or specific genetic biomarkers like ABCA4 or BEST1? Kindly update about this.
Okay, so the clinical clues, of course, are, I mean, starting from the personal history of the patient, if he refers that his parents also had the same condition, but they cannot specify what kind of macular degeneration they had, of course, the index of suspicion is high, because perhaps they didn't have a diagnosis, but perhaps it's the same thing, because most of them, the condition I showed you, are autosomal dominant or maternally inherited. So there is actually a risk in the parents. And when they also refer other symptoms other than decreased visual acuity, for example, I cannot drive at night, or I have intense photophobia, for example, for CACD, for example, this should raise suspicion this is not just AMD. And as for your second question, type 2 neovascularization are largely predominant in IRDs compared to AMD that, for example, is more type 1 or type 3 kind of neovascularization. So if you find these huge subretinal hemorrhages, you should perhaps think about something else. Perhaps also other conditions, I mean, for example, peak or multifocal choroiditis can present with type 2 neovascularization or myopic CMV, for example. Usually when you find type 2 neovascularization, it's one of the two. So that's my take on it. And when you, of course, when you do the fundus autofluorescence, if you have it available, and I know that nobody, I mean, not a lot of people can have access to this exam everywhere and every time, but if you have it, it's a useful tool, in my opinion. Sorry.
Dr. Lorenzo, if a patient comes and present late to us with late signs of geographic atrophy or macular neovascularization, about the timing of these genetic tests, what is your opinion? And what tests should we start with?
Okay, so in Italy, it depends a lot from the country. When the test is provided by the national healthcare and insurance, I mean, offer the test if the suspicion is relatively high and the patient is interested in knowing what kind of diseases they have, because they have family and they want to, generally speaking, I would advise like this, and we normally offer whole exome sequencing. Again, I know that this is not everywhere and every time is like this, so we basically sequence all the genes that are known to be part of our body, because perhaps we don't know that one gene causes macular degeneration today, but we will in 10 years, and we want to get back to the results and check without doing another test. Until to 2023 was a panel-based approach. So we just sequenced the genes that were known to cause the condition. But for example, if you find a patient that looks like Leventinese, this is really typical, or Sorsby's, you can just sequence the gene. That is really straightforward. You can ask a laboratory. I mean, sequencing of one gene only, one variant, is not that costly. So you can arrange perhaps with a smaller laboratory and ask them, can I send you the blood of some patient that I think that have this mutation? And also knowing about the epidemiology of your region. For example, in Italy, we know that some particular variants are associated with Sorsby's compared to other regions. And this can help because you check just this variant and you are done.
Dr. Lorenzo, what are the implications of these correctly distinguishing ARMD from inherited retinal diseases, as far as the prognosis and counseling, and particularly about the future gene therapies? What's your opinion about that?
In my opinion, it's really important. I, I, I see some, okay. I take care of these patients, so for me it's really important. But it's, prognosis wise, you can check their OCT and adjust their follow-up according to the risk that they will develop complication. As you saw, if left untreated, these are really bad conditions. And of course, some of them have systemic implications like mitochondrial retinopathy or pseudoxanthoma elasticum. You want you to give them a correct diagnosis. And as far as gene therapy is involved, for the vast majority of them, there is no immediate cure. But for example, for Best disease, we recently saw that gene therapy is coming, it's one phase 1 trial. So you don't really know what's going to happen after 5 years. These are really relatively young people. I mean, 60, 65 is young for me. And perhaps they want to be put in a database that will allow them to benefit from one therapy that may become available later on. And of course, the familial counseling is important, and the screening of individuals that may be at risk. That's for me the main reasons I do the genetic testing.
Very rightly mentioned. And thank you, Dr. Lorenzo. You have explained almost touched every point in detail. And it's a really important topic, very important, because we see these patients in our clinics. And sometimes the things are so overlapping that we miss these. And if things go wrong right in the beginning, then in diagnosis and, of course, prognosis and treatment, everything becomes a challenge. So these things I believe will be very beneficial for our audience, international, virtual, who will be attending your lecture, and it will help them in differentiating whenever such patients come to. They will keep these points in their mind, and it will be beneficial in their clinical practice. I want to thank you on the behalf of our all international audience, and we are looking forward to more educational sessions with you in future. Thank you, Dr. Lorenzo.
I thank you, Dr. Mirza. Thank you so much.